Hey, everybody. Welcome back to another episode of Pulm PEEPs. Thanks for joining us today. Monty, good to see you, as always. The best part of our week, as we always say.
I know. Great to see you, Furf, and really excited to be back and recording with you and really excited for our episode today. We're going to be doing our second collaboration with BMJ Thorax, and we've had a really great journal club with them that we released not quite a few weeks ago. But for our listeners today, we want to just remind everyone BMJ Thorax is one of the world's leading pulmonary and respiratory medicine journals and is really publishing groundbreaking pulmonary and critical care research articles. It is the official journal of the British Thoracic Society and it's regularly shaping the landscape of pulmonary and critical care medicine as we know it. In addition to their mission of advancing research and clinical care, Thorax is dedicated to medical education as well, and so happy for us to be rejoined by one of the associate editors for education, Chris Turnbull. Chris is an associate editor for education at Thorax, as I just mentioned. He's also an honorary researcher and respiratory medicine consultant at Oxford University Hospitals. In addition to this role, he's also a prominent researcher in sleep related breathing disorders. And Chris, so great to have you back on the show today. Honor to always have you on Plum Peeps, and not only today, but really looking forward to our collaborations going forward.
Thanks very much, Christina. Yeah, it's really great to be back and fantastic to have the opportunity to continue this collaboration and to talk about another great journal club today.
Yeah, absolutely. And as a reminder to our listeners, what we do in this series is we talk about a journal club article that was written for BMJ Thorax. And because of that, we get to connect with some really great junior researchers and fellows. And today we're joined by Ewan Mackay. He wrote the BMJ Thorax Journal Club article for October 2024. He is a respiratory clinical research fellow who started his PhD in London. And his research focus is on chronic cough and the development of new patient-reported outcome measures, as well as respiratory physiology, particularly in relation to exercise and disease. Ewan, thanks so much for coming on Pulm Peeps.
Thank you. It's a privilege to be here. And thank you so much for taking the time out of your busy schedules to do this. I'm a little nervous, but also excited to be doing something like this.
No need to be nervous. You're doing great already.
I know Furf and I are nervous every time, but you're
Yeah.
going to have fun. And you've
Okay.
prepared such a great journal club, and what you wrote and published in BMJ Thorax is amazing. So, really just excited for you to tell us a little bit more about that. And really, before we get into the latest articles that you highlighted you in, wondering if you could tell those listening today, how did you go about choosing these four articles for discussion?
Yeah, good question. Thank you, Chris. So I'm currently doing a PhD in chronic cough, and we see quite a lot of overlap with patients that have airways disease. And quite rightfully, biologics have received a lot of attention, certainly at the British Thoracic Society and the European Respiratory Society conferences. There were lots of papers on when somebody has established COPD about reducing exacerbation and helping with lung function. But what I wanted to do was I wanted to take a very kind of different approach and to look at some papers that covered the life cycle of COPD from early detection all the way through to important kind of complications. And I hope by doing this, we can shed some light on the natural history of disease and perhaps provide a better understanding of how we can prevent patients from developing COPD and identifying those that are at risk.
Yeah, sounds like a very cool way to approach it and a great focus. And I think this smattering of articles really covers a bunch of those different aspects. And so I'm excited to discuss all of them. So let's dive in. The first study that you just chose to look at was about the impact of household air pollution on various respiratory outcomes. This is a topic that obviously is super important in pulmonary medicine. We haven't done it in a ton of detail on prior episodes, but we're happy to start with this and shed some light on the health impacts of gaseous fuels, given their significant health implications. And I think we'll have some episodes coming down the pipeline looking in more detail. But could you share the purpose of the trial that you looked at and what it aimed to study?
Yeah, absolutely. So I think this is a very timely article and it sheds a lot of light on energy sources that we use for cooking and for heating. And I think particularly a lot of the studies looked at less economically developed countries. The WHO estimate that there's over 3 million deaths every year due to household pollution. So this is clearly something which is really important. It was a systematic review with a subsequent meta-analysis. And the purpose of the trial was to compare respiratory outcomes So, but by outcomes, respiratory symptoms, so they looked at cough and wheeze, the development of COPD, as well as mortality and birth outcomes. And what they did is they compared different fuel sources. So they grouped fuel sources together. So this looked at gaseous fuels, so mainly kind of natural gas, and then compared that to fuels that are more polluting and also fuels that are less polluting, such as electricity or solar. And the authors looked at cooking and heating in particular. And I think the reason they did this is because they wanted to look particularly at the domestic environment, which disproportionately affects, on average, women and children who, in general, spend more time in the home, as it were.
Yeah, thanks so much, Ewan. And really, such an important and really glad that you picked this article is because, as you said, I think it's shedding light to something that is we feel and or is impacts people on a. Sorry, I'm gonna repeat that. Thanks, Ewan. This was a really great article, and so glad that you picked this because I think it highlights some really important topics and some implications that people worldwide are going to be exposed to. I'm hoping, though, you can talk you alluded to some of this earlier, but hoping you can walk us through a little bit more about the exposures and the specific interventions in the study. I know that you mentioned they looked at more polluting options such as wood and kerosene, trying to compare that to potentially less polluting options, as you mentioned, electricity and solar use. But hoping you can delve into that a little bit more for us.
Yeah, so we'll talk about it in a little bit more detail later, I'm sure. But there was quite a degree of kind of heterogeneity of studies that they looked at. But essentially, they wanted to group different fuels into three main groups. So they looked at gaseous fuels. This is a bit of a nebulous term, but it includes mainly kind of natural gas, which, for example, I've got gas in my house. I'm sure lots of people do. But it also includes liquid petroleum gas, which is mainly butane or propane, and also biogas, which can be produced from agricultural products. But the base of that tends to be either, well, it tends to be methane. So those are the gaseous fuels. And then in terms of more polluting fuels, they looked at wood, charcoal, coal, and also kerosene. And then they looked at fuels that are deemed to have no emissions at the point of contact. And what I mean by that is the end user who uses them doesn't have any emissions. So that would include, for example, electricity or solar use. So what this study didn't do is it didn't look at wider environmental impacts. It was focused on the people at home who are doing the cooking and the heating. And they looked at a very large number of trials. So actually they managed to find over 48,000 papers initially from their screening, and then managed to draw that down to 116 studies in total. So this is a really good number for them to be looking at in terms of their outcomes of respiratory outcomes and also in relation to mortality and births as well.
Yeah, thanks you. And an enormous scope for this trial. I actually really love the broad scope and approach they took, even though it includes this very heterogeneous mix and very sort of different decisions between some places where polluting fuels are very common, and there are some countries where polluting fuels are extremely uncommon. But I think this is applicable in the home for anybody who's making these sort of decisions or making health policy related decisions. I know personally, my oven broke like 6 months ago. I have a son who's 18 months old. And then there was this whole decision about whether you're going to get gas or electric. And obviously that may have less impact over here than when you're thinking about kerosene or wood burning, but those may impact patients that I see in the clinic. So I really love the broad scope. Very impressive meta-analysis or systemic review looking at 48,000 papers and getting down to 116. So I'm hoping you can tell us what broad findings they found in this enormous collection of papers.
Yeah, absolutely. So when they compared gas to more polluting fuels, they found that using gaseous fuels reduced the risk of respiratory symptoms, so cough and wheeze, reduced the numbers of pneumonias by almost half. And actually, the odds ratio for developing COPD was 0.37. So it really decreased that quite significantly. Mortality was also decreased, and as were low birth weights and preterm births. What was interesting is they then looked at the gaseous fuels compared to electricity and solar. and found that the risk of COPD with gas was slightly higher. It was an odds ratio of 1.15, which was just outside of the cusp of 1. And there was also a slightly increased chance of developing pneumonias. But what was really interesting when you compare them is that the difference in outcomes between the gaseous fuels versus the highly polluting fuels was really quite marked, whereas the differences between the gaseous fuels and the fuels with no emissions was actually much, much smaller. So I would say that I think this is a fantastic study, which is why I included it. But there's a lot of observational studies and only 2 randomized controlled trials were included. The vast majority were cross-sectional studies, which are, of course, important, but they can't prove direct causality. Of course, randomized controlled trials are very difficult ethically to carry out. They're very expensive to implement, particularly in lower and middle income countries. And a lot of the included studies did have a lot of heterogeneity. And a few of the larger studies corrected for big confounders, such as ambient pollution and also cigarette smoke exposure, but not all of them did. So I guess my big takeaway from this is that the best option for people to go to protect respiratory health would be to go for electricity. But for almost 1 billion people in the world, that isn't an option. So compared to the more polluting fuels, such as coal and wood, moving to gas perhaps as a transitional stage before they have access to reliable electricity, I think would be a good way of protecting respiratory health and also birth outcomes as well.
That's so great, Ewan. Thank you so much. And really just love that final takeaway that you had, right? I think when we're going to be going through these articles, and an important thing that you're able to do from this is, what is your takeaway? Is this going to, right? I think we always ask ourselves, how are we going to change management? Or what are we going to do day to day based on results of a finding? So that's really important. But you alluded to such a great point, right? Not everyone is going to be in Dave's situation where he's going to have the choice to pick having to pick between gas and electricity, and from this, maybe I don't know for what you ended up choosing, which if you went with gas or electricity, but for some people that could be an option, but for those that's not, really understanding this from a medical standpoint as well as working with policymakers to help try to have meaningful interventions going forward. Another thing I liked particularly about the study too is, right, sometimes when we're reading studies, it's either a systematic review or it's a meta-analysis, but this actually combined both methods. And Chris, I'm wondering if you could walk us through some of the key strengths and limitations of using this combined approach.
Yeah, so thanks, Christina. I think you make a really good point about the policies and that needing these sort of studies highlighting the need for policy change. And I think in lobbying governments around that. I think the strength of this sort of study with us using both systematic review and meta-analysis together is that they're enabled to include and synthesize data and results from an incredibly broad range of studies. So we've already commented on that really wide scope of this paper. And I think that's really the main strength of the methodology they've used. We've alluded to some of the limitations already, particularly in the meta-analysis, that broad heterogeneity in the studies potentially affects how generalizable or applicable the results are to all groups. I think you also mentioned that there were relatively few RCTs in this, and that cross-sectional nature, it's then therefore hard to necessarily determine cause and effect. Potentially electricity use versus gas may be confounded by other factors in terms of access to better healthcare, potentially through economics in that country. But certainly I think the striking difference between the more polluting fuels and the gas is very marked, isn't it? I guess the other area of limitation in the study would be things like publication bias. Potentially only those studies which will find a positive result will get into being published in the literature. And it's important to bear a relation of that when looking at systematic reviews and meta-analyses.
Chris, those are some really great insights that you provided. And we'll definitely make sure with this journal club and accompanying podcast, you'll get access to the 4 articles that Ewan mentioned, and you'll get links that you can read to directly if you want to go into reading them further. But we're going to go ahead and go to the second study that was selected. And Dave and I, we've done a whole series on COPD here at Pulm PEEPs. And we know that without treatments that are currently available to, We know that without treatments currently available to reverse lung damage, early detection and risk factor management are really essential in caring for patients with COPD. This particular, though, study, the second one that you selected, evaluated advanced quantitative CT scanning as well as machine learning to detect subtle lung changes in young smokers. So I'm hoping that you can walk us through the goal of the study a little bit further and specifically the cohort that was used.
Yeah, of course. So this paper was published in the American Journal of Respiratory Critical Care Medicine earlier on this week, and it actually involved the British Early COPD Network. The acronym is the Beacon cohort, which is a bit more memorable. It's an observational cohort study, which exactly as you said, it sought to review if smokers with normal spirometry had early changes on the CT scan that could predict lung decline. So they had 430 odd subjects who were smokers but had normal lung function. And they had 68 then age-matched never smokers who were compared. Now, the smoking cohort, the median age was 39 years old, and the average smoking history was 16 pack years. Now, I thought that this paper was really interesting because the average age that we diagnose people with COPD is in their 60s. We're looking at a snapshot which is almost 30 years prior to this, which is what I think is remarkable about this study. And they followed the patients up for just over about 2.5 years on average with spirometry and this quantitative CT scanning, which essentially involves performing a CT scan, radiologists labeling areas of interest as, for example, ground glass imaging or emphysema, and then using machine learning based upon how the radiologists have classified these areas to essentially examine the volume of the lung and then provide a percentage. So you could say in this person's lung, there is 0.5% of the volume is occupied with ground glass, which I think is really quite clever.
Yeah, I totally agree with you. I like this article for a number of reasons. One is that I think developing these techniques that can use machine learning and use the high quantity of radiology data that we have to predict future outcomes is an evolving field that's going to be really important for us in protecting lung health in multiple conditions. I also think that it's important to try to stop decline in lung function very early. And so if we can detect it early, it might be the first step for exploring treatments in a cohort that ends up reducing a reduction in later lung function. Finally, I think no matter what, if I had a 39-year-old who was smoking, I would counsel them aggressively on smoking cessation and the health benefits of giving up cigarettes. And so this wouldn't impact whether I go towards tobacco counseling or not. That being said, I have found that with patients, it can be very effective to look at a CAT scan and point at cigarette related damage or point at findings. And if you knew that there were some collections here and you could say, hey, look, this area is already showing. And so even though you don't have symptoms and you don't have lung function yet, I'm really worried about this progressing, that might help in those smoking cessation conversations. So, Ewan, can you summarize for us what they ended up finding?
Yeah, thanks, Dave. There's a lot of data in this study to digest. So I'll just go over a few things that I found in particular was really interesting. So their headline finding was that there was a greater percentage of ground glass opacities, air trapping, and also a mark of airway wall thickness that they found in these smokers that had normal lung function. Now they found that ground glass, air trapping, and emphysema, these were found to be risk factors for greater falls in FEV1 every year. The bit that I found most interesting is that we're always taught at medical school, aren't we, that taking a history is key. And actually, this study absolutely backs that up. So in this cohort of smokers, almost a quarter of them actually had chronic bronchitis symptoms. And almost 60% of them actually had a CAT score of 10 or more, which is our cutoff of mild to moderate kind of impact of symptoms. So it's interesting that a lot of these patients, they may have subtle findings on their scan, but actually they are symptomatic. And if they are symptomatic with chronic bronchitis symptoms, they were found to have an accelerated drop in lung function of around kind of 30 mils per year. So if you can imagine that we're getting a snapshot 30 years before these patients on average are diagnosed, and they're symptomatic 30 years before, and they're losing over 30 years, if it's more than 30 mils a year, they could be losing a liter in their FEV1. So I think it gives us a real insight into points where we can potentially target these people for counseling them about smoking, showing them their scan results, everything that you talked about, Dave, in terms of communicating the risk to this cohort.
Yeah, I think so important and totally agree. Those are such great points, like how we can take this because I can imagine us being in clinic with a patient who is, but my lung function's normal. Like I'm normal. Like things are fine. I'm going to continue what I'm doing because there's no impact yet. So taking all of this imaging, showing them the counseling is going to be just so important. I think this study highlights that. And Ewan and Chris, I want to ask you both too, and you just alluded to some of this, but the early structural changes in young smokers that are going to be detectable with these advanced imaging techniques, how do you think these could influence screening guidelines or other early intervention protocols for high risk populations that we haven't mentioned yet? And I guess a even broader question, sorry for asking two, but could this potentially reshape our entire approach to COPD prevention?
I think kind of answering the second question first, I absolutely agree with Dave, and I'm sure all of us would agree that we always counsel our patients in terms of stopping smoking, and I don't think that necessarily changes our strategy. I think, as Dave said, it provides more evidence for us visually to show our patients that actually there is already lung damage, which is there, even though these patients are on average in their 30s. I think in terms of screening, certainly from this study, my kind of take home was if somebody is having symptoms of chronic bronchitis, or if they're getting symptoms that contribute towards the CAT, so shortness of breath, affecting their everyday life, these are the patients that may potentially benefit from early screening because they have the greater fall in lung function. Certainly moving forwards, I'd love to see further follow-up of this cohort with repeat imaging at set intervals. So for example, it'd be really interesting to know the changes that these patients have with an average pack year history of 16. If they stop smoking, do these changes go away? And I think with greater availability of advanced imaging techniques, I think that early imaging is likely to become a lot more important in identifying patients who are at risk of developing COPD.
Great. Chris, is there anything else that you wanted to add?
I think everyone's made really great points about this article. I guess the key intervention is smoking cessation, isn't it? And I wonder if scaling CT imaging regularly for anyone who smokes in the country or across the world is feasible. And that I wonder if there's also things around whether there can be educational packages from this in terms of saying this might not be your lungs, but because we haven't scanned them, but this could be what your lungs look like, and challenging that healthy smoker idea that actually you may think you're a healthy smoker, but probably there is already these sorts of changes in it. And that would be the sort of thing I would be really interested to see in follow-ons. Is it enough to say that this could be your lungs, or does it need to be a scan of your lungs to really give extra value in motivating people to stop smoking or other early interventions? But it's great in really highlighting and challenging that idea that I'm a healthy smoker because my lung function is normal.
Yeah, that's a great point about how it could actually be applied. And if we could study that and just start to study patient behaviors. I also think always with studies like this, not to sidetrack too much, is that these come up with pulmonary vascular disease too. Our advanced imaging is getting so much better. Our machine learning is so much better. But hemodynamic and physiology tests are still pretty old, right? Like we use spirometry, which is tried and true technique. And when we see abnormalities under spirometry, it can be really helpful. But I also wonder if we'll develop our physiologic testing and our functional testing to catch up with some of our imaging testing at some point. And I would be really fascinated if there are subtle differences in the flow volume loop curves for these patients that correlate with the imaging findings. Let's not take too much time. Obviously, we could talk for an hour about each of these studies, but let's turn to the third study. So in the third study, you looked at another study I was fascinated in about interstitial lung abnormalities and progression of emphysema of patients. I really like that you chose this. I think interstitial lung abnormalities, which we'll touch on a bit more, or I'm sure you'll tell us about it a bit more. For our listeners who don't know, this is an abnormality that we see on imaging. It's a small portion of the lung, usually defined as less than 5%. It's usually in a non-dependent portion, so we're not just thinking about atelectasis. And it's becoming a really impactful field for patients with COPD, with interstitial lung disease, with cancer, because they are not quite nodules. It's not like we have guidelines to follow this. And it's just something that's abnormal that doesn't meet criteria for another quite imaging finding. And it's, I think, going to end up playing a big role in how we monitor patients and promote lung health going forward. I'm hoping you could tell us a bit more about this specific study and what they were looking at with these ILAs.
Yeah, absolutely. It's a similar flavor almost compared to the last trial. It was again published in the Blue Journal. It's a very dense paper. It had quite complex statistical methods, particularly in the results. So I'll try and summarize this. But it included a really large cohort of patients, and I think its take-home messages are really helpful. So they essentially there is a group that's been tracking a cohort over time as part of an observational cohort study. They included 2,700 patients, and almost 1,700 of those patients had COPD. And then they compared them to non-smokers who had normal spirometry. And they had visits which were 12 months apart and phone calls every 3 months to find out if the patients were still alive, if they'd had any exacerbations at all. And they again performed quantitative CT scanning, which we talked about in the last paper. So labeling aged areas as ground glass, emphysema, and then using machine learning to then provide a percentage of the volume that these occupy. The primary outcomes that they were looking for were actually related to systemic inflammation. So they wanted to look at white blood cell count and neutrophil count in particular, and the change in emphysema from the CT scans, which were 1 year apart. And then the secondary outcomes were focusing on change in FEV1, progression to COPD, and also looking at exacerbations and mortality.
Great. And love this paper that you picked as well, you. And I think so important. And obviously there's been a theme in them and why you chose them. But I really think, again, as was already mentioned earlier, with newer advanced radiologic studies as well as machine learning, how that's really going to be changing the field and what we can learn from that. Specifically in this, and I was just reviewing someone's trainee's grant recently too, and I'm sure that there's going to be definitely some limitations or people are going to have questions, those with COPD and those without, and how systemic inflammation is going to be maybe skewed in one group versus the other. But would love for you to tell us a little bit more about the key findings that you found in this, right? So again, this study was looking at the presence of GGOs, systemic inflammation, and several respiratory outcomes, including mortality, though. So yeah, you would take us through what your takeaway from this, and does it change what you would do or how you would, proceed?
Yeah, thanks for that. The main kind of takeaway messages. So current smoking and previous cigarette smoking were both associated with an increased percentage of ground glass opacity. And there was a very clear stepwise increase in the percentage of ground glass from non-smokers to former smokers and finally to current smokers. So I guess actually this paper adds to some of the detail from the last paper, because I would like to see them following them up to see if changes are reversed or not. And we can't necessarily prove causality here, but what we do have is a stepwise increase showing that former smokers are somewhere in between current smokers and non-smokers. An increased ground glass opacities was associated with just over a 10% increase in developing emphysema at 12 months. And the percentage of ground glass opacities was also associated with all-cause mortality and exacerbations. They also found that having more ground glass was associated with systemic inflammation and also with higher neutrophil counts. But I guess you're asking about my takeaway from this. As we'd spoken about before, looking at ILAs and ground glass opacities, they're not associated with just one lung pathology. So going back to what ground glass opacities are, essentially they are parenchymal changes where you can still see the vasculature and the architecture underneath. And it means that it's not associated with any single lung pathology. So ground glass could be related to infection, inflammation, fluid alveolar collapse, or they could actually be related to interstitial changes. I think it would have been helpful to have had, if they tested transfer factor, I think that might have been useful to assess alveolar damage as opposed to looking at a volumetric analysis of kind of emphysema. And in their analysis, they also looked at changes in density, which I think is a little difficult, especially with the machine learning element, because a machine will record a ground glass opacity resolving as actually counting as a decrease in density, which may also infringe on what they count as emphysema. So I guess without in-depth knowledge of their computer learning program, it's quite difficult to know. Also, as an early researcher reading this article, I think it's got very large numbers. It was very robust. a lot of the figures that they had in their tables were natural log figures of statistical tests, which it's difficult to interpret the kind of the clinical meaningfulness of these figures. For a lot of the main kind of headline figures, it was converted back into percentages, but a lot of the figures were with the natural log, which I can imagine was probably to make the data more normally distributed. But I think as a reader who's early on in their research, it made the reading the results a little dense, I would say.
Yeah, 100%. I think this is one of the things that comes up with studies like this is they're fascinating and they're really important, right? To propel the field forward. That being said, because of the intricacy of the technique, because of the early nature of the findings, and because of the way it's presented, there can be a lot of steps between knowing this fact and knowing how to implement it or end up applying it to patient care. So, Chris, I guess I'll turn to you with that. Is now that we have some idea based on this that these ILAs are important, but in this very sort of research experimental protocol, what are the implications of that, if any, for clinical practice, and maybe what steps would need to happen before we could translate these findings into our practices?
Yeah, I think these have got one of the key areas I think that these will have implications is within things like lung cancer screening programs where lots of these abnormalities and ILAs are picked up. And then it's to work out what the significance is of those in any given individual. And I think there'll be a learning process there in that we'll be needing to screen people in whom we detect ILAs for symptoms. We'll be needing to perform spirometry and probably performing follow-up low-dose CT scans longitudinally to see what develops from these. So I think it's going to be a massive piece of work, and it's going to mean that teams are going to need to develop pathways to be able to cope and give the best management for people in whom we detect ILAs. I think the machine learning, it's really interesting thinking about the black box nature of some of the things they're saying, which we then sometimes struggle to understand exactly how you've gotten to results. But I think the potential advantage of machine learning is it may be able to help with some of the burden of that follow-up that these people are going to need over time.
Yeah, that is also a really interesting point you bring up about like doing repeat low dose CDs. It would be interesting to know for patients who are already getting this, like we have evidence for doing lung cancer screening in patients with a certain smoking history. So that's obviously a different population than looked at here. But it would be interesting to apply this to scans you're already getting, because I think right now we're really only using those for the proven protocols for screening for lung cancer. But it would be interesting to see if there was prediction for other things in real practice. Maybe a future study to come that we can work on together.
Love thinking about how these implications are and how great they've been, but even what we can do to move things forward. So the first three articles, briefly to summarize, we talked about how policy may be implemented and is going to be needed. We talked about machine learning, early screening, possibly early prevention to prevent respiratory related outcomes to chronic lung disease. But so we're going to now turn to our fourth and final study, Ewan, that you wanted to highlight during your journal club. And this is actually looking at potential therapeutic options in patients with PH COPD. So those patients with pulmonary hypertension, COPD overlap. Ewan, so go ahead and tell us a little bit more about the author's study design and the cohort that was used for this study.
Absolutely. So we've come right to the other end of the spectrum here. So instead of early diagnosis or trying to prevent COPD, this is in patients who actually have COPD associated with pulmonary hypertension. And we know that these patients do worse, both in terms of symptoms, and they also have a reduced survival, which is independent of lung function. Now, this trial was called the Perfect Study, which is why, as I recall in my thorax article, I think I had a terrible pun. And it follows on from the success of the INCREASE study. So for those of you that aren't aware, the INCREASE study was published in the New England Journal, I think about 3 years ago, and it showed an improvement in 6-minute walk distance in patients who had pulmonary hypertension associated with ILD. And that was using inhaled, which is a prostacyclin kind of analog. So with this particular trial, they wanted to try the same drug, treprostinil, in COPD patients that have pulmonary hypertension. So the trial included patients who were more towards the severe end of the pulmonary hypertension spectrum. So patients on right heart catheterization needed mean pulmonary arterial pressures greater than 30 and more than 4 Woods units. And if I can recall correctly, please do correct me, but I think the recent change in pulmonary hypertension guidelines, the diagnosis is a mean pressure greater than 20. So this is patients that towards the more severe end of the pulmonary hypertension spectrum. Now, all of the patients in the study, they actually had a slightly odd trial design. All patients had a run-in period with inhaled treprostinil, first of all to assess for tolerance. They then aimed to do a crossover study. So patients had 12 weeks of treatment period 1. They would then have 1 week washout, and they would then have another 12 weeks of the other treatment, whatever it may be. But they also had a contingent design. And this isn't something that I'd seen a lot before, but it was they'd contacted the FDA during the trial because they'd had large quantities of dropouts. And it was recommended that they had a contingent design where if they did have too many dropouts, they could actually have a parallel arm. So patients are randomized to placebo or the medication in conjunction with a cross-sectional study. The primary endpoint that they were looking at was 6-minute walk distance after 12 weeks of treatment. And secondary endpoints looked at symptoms. So, for example, Borg scale, looking at breathlessness. They also looked at some quality of life questionnaires like the St. George's questionnaire. They looked at BNP, and also how the patients felt globally was also another one of the secondary endpoints that they used.
Thanks, Ewan, for going through that. I love all the trials that you looked at. This is my favorite one. As someone who practices pulmonary vascular disease, I think that group 3 pulmonary hypertension secondary to lung diseases has been a long vexing problem. And so everybody was very excited by the increased trial and having a therapy that they could apply to PH-ILD. But PH-COPD remains a very tough nut to crack. And it's interesting to see a study exploring that. One goal of journal clubs is not only to have this great review of recent practice-changing literature, but it's also to get better at reading trials and how to interpret studies. So Chris, as the BMJ Journal Club editor, you're our resident trial expert. I was hoping you could walk us through a little bit about this crossover trial design and how this is applied and how it can be useful in studies, or if there are any limitations to be aware of.
Yeah, fortunately, I did my PhD running a crossover study, so I'm quite well versed in the trials and tribulations of crossover studies. I think the great strength and the attraction of doing a randomized crossover study is in increasing your statistical power because you're making comparisons within the same patient, and that can dramatically reduce your sample size. Then we come on to the challenges, and I think those challenges are partly something that this trial saw, and that was a reason for their contingent design here. Before coming onto that issue of dropouts, though, I think one of the major issues with crossover studies designs is in whether there is a crossover effect or an effect whereby if you have the treatment in the first arm, you still are having an effect of that treatment in the second arm because the washout period in the middle is insufficient. And that can be a real challenge as to how you handle that statistically, and it can make it very difficult to interpret the results of these studies. But then the second issue, which this study I think came across, is that of the problem of dropouts, and that if someone drops out from either arm, they then are really not going to contribute data to analysis, your pairwise analysis between those two arms at all. And certainly if you have studies whereby you're going to expect a high dropout rate with a fairly long follow-up period here of 12 weeks, or if people are being admitted to hospital and then needing to be withdrawn from that or having exacerbations, then that can be a real problem. And they're also fairly obvious point, finally, but they're not suitable for certain outcomes like death and others.
Thank you, Chris. And I feel like there's not a question that you can't answer. So appreciate your insight and input. And Dave, I knew this was going to be your favorite study as well.
Yeah.
You in your actual the journal club that you wrote in BMJ Thorax, you highlight this trial was stopped early due to safety concerns. Can you tell us a little bit more about the results and specifically the risk observed with treprostinil in this patient group? And any insight as to why this is the case?
Yeah, absolutely. And especially with that last point, I wish I had the answer. So they originally planned just over 130 patients, and they only ended up recruiting, I think it was 70 odd patients, as the trial was ended early, as you said, due to safety concerns. So First of all, they had noticed that the primary outcome, so the 6-minute walk distance, had actually increased in the treatment arm by almost 5 meters. In the study, 6 deaths occurred in the treatment group, and that was compared to 0 deaths in the non-treatment group. We should also bear in mind that, of course, patients that have severe pulmonary hypertension associated with COPD, they are a very sick cohort, but nonetheless, there were 6 deaths compared to 0 deaths. It was also suggested, although they didn't give any figures, that it actually increased the number of hospitalizations. And certainly the number of adverse events was 26% in the treprostinil group versus 10% in the other group. Interestingly, there was an open label extension part to the trial, and results are yet to be published, but it might be quite interesting to see if there were any patients who did potentially benefit from the treatment at all. I'm not sure why it didn't demonstrate any benefit in this patient cohort. I'd be interested to hear what Dave kind of thinks about this, and what anyone thinks about this. The study certainly had recruitment difficulties, understandably, over COVID. And I certainly think that larger trials are required to definitively answer the question of who may benefit from inhaled treprostinil. Perhaps, I suppose, the next steps. So the INCREASE trial showed that patients with ILD and PH received benefit. This showed that patients with COPD did not. A trial looking at patients with mixed emphysema ILD may be the best kind of first step. Post hoc analyses of INCREASE have noticed that greatest benefits were in patients with IPF or connective tissue related ILD. But I do wonder whether there are other cohorts that they could consider large trials in to see if they get benefit.
Yeah. Oh, Chris, go ahead.
I was just going to come in. So we've mentioned with this study that the increase in 6-minute walk distance, but how that's not a relevant result. And I think it's just to highlight the points about the minimally clinically important difference as being relevant with this. And in 6-minute walk distance, I think you're generally looking for an increase of around 30 meters for that to be deemed minimally clinically important. I don't know if that differs in this population group, and that's why we're saying whilst there was an increase, it wasn't a clinically relevant increase.
Yeah, absolutely. We've talked about that in a bunch of our rapid fire journal clubs about 6-minute walk. It can be a great metric correlated with lots of important findings, but you really do have to achieve that clinically meaningful difference. Yeah, it's always a disappointing study. We'd love to have a therapy for patients with COPD and pulmonary hypertension. Obviously, there's a lot of factors that go into this. This study, as you mentioned, had a bunch of challenges. There was a challenging time period with COVID playing a significant role. I'm also curious about the crossover design for patients who have pulmonary hypertension. Really, the sustained benefit is in right ventricular remodeling. So doing sort of a crossover might negatively impact some of that. Also, COPD is just a very different physiology that leads to pulmonary hypertension than ILD. Hypercapnia playing a significant role, areas of large lung destruction, which can have an impact on the vasculature. Unclear if an inhaled therapy will be delivered effectively and will end up having a positive impact eventually. And then always interesting about adverse events. Inhaled treprostinil can cause quite a bit of coughing, sometimes pneumothoraces, things like that. And you just wonder if the physiology is different in the lung disease for COPD than ILD. But no matter what, an important study to know about in the field, both for taking care of COPD patients and pulmonary hypertension patients, and a good launching off point for more to come. I think that brings us to the end of our time. This was an awesome episode. I think 4 really great articles, and we love diving into them with you guys and partnering with BMJ. This has been really great.
Totally, and definitely excited to invite our fellows within our Pulm PEEPs network to reach out to us with any ideas. You and you did such a fantastic job, and if there's others listening today, if you have a few recent articles you want to review, we can discuss with you and hopefully submit to have both the publication and BMJ Thorax as well as a Pulm PEEP episode, just like we're doing today. Chris, as a BMJ Thorax representative, anything you want to add on that?
Yeah, no, I agree. I'm really delighted to continue this work and to continue collaborating with you guys. I'd be really happy to hear from anyone who wants to contribute to Journal Club. It's something where if people are interested, they can drop me a line. I think you can put my email address, hopefully, in the link. So if people do want to get in touch, generally what people are doing with journal clubs, as much as Ewan's doing, is picking 4 recent articles from within the last roughly 12 months on a theme, which I think Ewan's done fantastically today. And then we're getting that submitted and written up as a journal club. So if people have ideas for that, please do get in touch.
Sounds great. Thank you all so much for listening. You can listen to this episode both on our feed and on the Thorax feed, and make sure you join us next time.